Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities: the Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community. Hello everyone, and welcome to Children's Healthcare Canada's Spark Live webinar series. I'm Doug Maynard, your host for the next hour. Spark Live, of course, is where we gather each Wednesday to curate and convene and showcase excellence and innovation from across the child and youth healthcare community, with our goal to spark conversation, ideas, and action. And since we are live, as always, I do want to remind you that you do have the opportunity to ask questions at any time. So please do type those questions into the question box as you think of them at any time throughout the presentation. Then we have them available for us when we're ready to take questions at the end. And also, if you're so inclined, please do feel free to share your thoughts on Twitter, and be sure to tag us at Child Health Can. All right, so today we're going to be talking about the child and youth mental illness epidemic, and we're going to be confronted with a couple of difficult questions asking, is it real? Can it be prevented? But I do want to point out that we're referring specifically to that word epidemic in the title. There was a bit of a conversation on Twitter as we were promoting this session, where people expressed some concern that asking the question around mental health, is it real, delegitimizes the experience of people with mental illness. But I want to stress, we're not questioning mental illness as a problem, as a significant issue in Canada, only in the context of framing the mental health or mental illness as an epidemic today. So we're really focusing on that word epidemic, and I just wanted to be clear about that. So today we're going to be looking through the lens of an epidemiologist who is going to present what current research and evidence tells us about trends in the prevalence of child and youth mental illness and suicidality, and he's going to review recent research on health promotion strategies that might be working to reduce the burden associated with mental illness. So joining us today to do all that is Dr. Ian Colman. Dr. Colman is the Canada Research Chair in Mental Health Epidemiology and is an Associate Professor in the School of Epidemiology and Public Health here at the University, or here in Ottawa at the University of Ottawa. Dr. Colman also directs the Applied Psychiatric Epidemiology Across the Life Course Lab, or also known as the APEAL Lab, which investigates longitudinal and life course processes surrounding the epidemiology of depression, anxiety, and suicide. So without any further ado, it's my pleasure to hand the virtual podium over to Dr. Ian Colman.
Thanks, Doug. Thanks for the introduction, and thanks very much for the invitation to present today. For the audience, I hope that you're either going to learn something new today, or also, and I think there may be a lot of this, confirm something that you've already suspected, and perhaps I'll be able to show you that there's some evidence around what you think might be helpful for mental health. Before I get started, I just want to acknowledge the fantastic team that I work with. I'm really fortunate to work with an amazing group of research staff and graduate students who really do an amazing job of making me look like I know what I'm doing. This is the Applied Psychiatric Epidemiology Across the Life Course Lab, and if you like any of the research that you see today, they deserve all the credit. And I'll just quickly acknowledge our funders and our collaborators in Canada and around the world. So I'm an epidemiologist, and I think a really good place to start when we talk about mental illness is to look at some numbers. And I think this is a really striking graphical representation of some big numbers. So this is data from the World Health Organization Global Burden of Disease study. And what you're looking at is years lost to disability by age group. So we have different ages along the bottom, and then rising up are years of loss to disability. And they're color-coded for different causes. And I think what you'll see is that if you look at younger ages, particularly from age 5 until the end of adolescent, the predominant color you're seeing there is clearly green, and those are mental and behavioral disorders. So they are by far the number one cause of disability around the world, up to kind of mid-adulthood, actually. And when we look at the most recent numbers for mental disorders and how common they are, the 2014 Ontario Child Health Study results have just been published 2 months ago in the Canadian Journal of Psychiatry. This was a population-based study where children were recruited from across the province of Ontario. They were interviewed between October 2014 and October 2015. There was about 3,800 children between the ages of 4 and 11, and for those children, their parents were interviewed about numerous different symptoms of mental illness. And between the ages of 12 and 17, the youth themselves were interviewed. About 2,700 were interviewed, and they reported themselves on their own symptoms in structured interviews. And these were done by Statistics Canada trained interviewers in the participants' home. What did we find? Well, when we look at children between the ages of 4 to 11, depression is pretty rare, only about 1%, but anxiety disorders are quite common, almost 9%. Attention deficit and hyperactivity disorder, around 10% of kids meet criteria for that. And then behavioral disorders, oppositional defiant disorder or conduct disorder, about 8% of kids are affected. So that means that among, this is before adolescence, 18% of children in Ontario are meeting criteria for a mental disorder. Similarly, when we look at 12 to 17-year-olds, we see a big jump in depression, 7.5% meeting criteria for depression, 15% meeting criteria for an anxiety disorder, 6% meeting criteria for ADHD, and around 8% meeting criteria for oppositional defiant or conduct disorder. And so for this age group, we're seeing 21, almost 22%. That's more than 1 in 5 who are meeting criteria for a mental disorder. So these are exceptionally common disorders. And when we think about suicidal thought, which is associated with many of these disorders, we can see that that really kind of ramps up in adolescence. So by the time kids are 15 to 19, we're looking at somewhere between 5 and 12% of children are agreeing to the statement, "Have you ever seriously considered committing suicide or taking your own life?" And I'm going to take a very brief aside here to encourage people not to use the phrase commit suicide. The reason is that the etymology of the word commit is directly linked to committing a crime. Suicide has not been a crime in Canada for more than 40 years. StatCan, unfortunately, used this wording for several years. I think they have finally phased it out, but I would encourage you to use phrases such as somebody taking their own life or dying by suicide, and not using the phrase commit suicide. Regardless, again, suicidal thought is very common. And it's, really disheartening to see that one of the leading causes of death, particularly for young people, is suicide. So these are percentage of all deaths caused by suicide by age. So you can see on the left, when you look at particularly, as you get to late adolescence, almost 1 in 4 or 1 in 5 deaths by adolescents are due to suicide, which makes it the second leading cause of death behind motor vehicle collisions. And that's upsetting for all sorts of reasons, particularly because when a young person dies by suicide, they lose many years of potential life. So it can be decades of potential life that they've lost. And I think it's really instructive to look at suicide and compare it to heart disease. And you can see that in this graph. Heart disease is the leading cause of death in Canada, and it gets a lot of attention. But although young people can be affected by heart disease, it's mostly elderly people who are dying from heart disease. So their potential years of life lost are actually quite few, whereas suicide affects people of all ages. And so when you add up all the years of life lost due to suicide, you get to a number that's actually not that far off from the years of life lost to heart disease. Which raises the question, is there an epidemic of mental illness? Because, there is certainly a huge burden. There's many, many people who are affected by mental illness. Well, if we look at the dictionary definition of an epidemic, we see one here: the occurrence in a community or region of cases of an illness, specific health-related behavior, or other health-related events clearly in excess of normal expectancy. So this is kind of the idea that things are getting worse over time. So I think, let's ask that question: are things getting worse over time with respect to mental health, particularly among young people? Well, if we ask the media, I think the answer is overwhelming yes, because we see headlines like these: living in America will drive you insane, literally. Crazy every day, America's mental illness epidemic. Everything hurts inside the teen depression epidemic. Mental disorders skyrocket. Try this to avoid becoming the next victim. Epidemic. Half of US teens meet criteria for mental disorder. Number of anxious kids skyrockets. We are failing young Canadians on mental health. And demand for youth mental health services is exploding. And perhaps this is something that you're experiencing in your clinical settings. But we wanted to investigate whether or not this was actually true, because certainly it appears to be, and there's a public perception that may be led by the media that there is something going on. So we looked at a study that was run by Statistics Canada called the National Longitudinal Survey of Children and Youth. And I'm going to talk about this study a few times this morning. This was a study where children and their parents were contacted every 2 years, starting in 1994-95, and it ran until 2008-2009. We were interested in children between the ages of 10 to 15 years because that is when they started reporting on symptoms of mental illness themselves in structured interviews. And several thousand adolescents were interviewed. And the things they were asked about were symptoms of different disorders. So there was 6 domains with several items in each domain. So one of the domains was depression and anxiety. So people had to agree or disagree with statements like, I'm unhappy or sad, I worry a lot. The next domain was hyperactivity. So statements like, I can't sit still, I'm restless. Social aggression, when I'm mad at someone, I say bad things behind his or her back. Conduct disorder, I kick or hit other people. And then with regards to suicidality, during the past 12 months, did you seriously consider attempting suicide? So these are not casual thoughts, but quite serious considerations. And during the past 12 months, how many times did you attempt suicide? So when we look at the trend over time, what we're going to see along the x-axis here is time from the mid-90s to the late 2000s. And along the y-axis, we have symptom severity. So if kids have very high symptoms, they're going to rank very highly. So the headline number of anxious kids skyrockets would lead us to believe that we're going to see a line that is going to be low in the mid-90s and very high in the late 2000s. But when we look at symptoms of depression and anxiety, what we see instead is a relatively flat line for 10 and 11-year-olds, same thing for 12 and 13-year-olds, and 14 and 15-year-olds as well. So that certainly doesn't match what the media is telling us, at least. When we look at symptoms of hyperactivity, we see that it's pretty flat over time, maybe a slight increase, but it's not very consistent between the age groups. We look at social aggression. We see that things are relatively flat, possibly declining over time. Conduct disorder, again, very flat over time. Suicidal thought, flat, possibly decreasing over time. And suicide attempts, again, we appear to see a decrease over time. And we're not the only group that has observed this. So this is actually among the adult population. If things are getting worse among adolescents, those adolescents become adults. So we would expect to see things increasing among adults as well. But we don't see this. So again, this is Canadian data from a StatCan study called the National Population Health Survey. On the left, you see major depression. On the right, symptoms of distress. So those are common symptoms of anxiety and depression. And again, we don't see much evidence of an increase over time. Things look relatively flat. Another study that my group was involved with using data from the Canadian Community Health Survey, we were looking at suicidal thought among young adults, so age 18 to 24, that's what's on the left, and compared that to 25 to 44-year-olds on the right. In both groups, we see that the prevalence of suicidal thought is relatively flat over time. So the conclusion we drew from that was that the prevalence of symptoms of mental illness in Canadian adolescents and adults has remained relatively stable from the mid-90s to the late 2000s. This paper was published in the Canadian Medical Association Journal a few years ago. And how many headlines do you think that study got? Well, I can't see a show of hands, so I'm just going to have to tell you that this study got 0 headlines. The media is not interested in a relatively good news story. It's much more fun and easier to sell newspapers if you're talking about bad news. So why do people think that there's an epidemic? Well, I think there's 2 related reasons that likely explain this. The first is that over the last 10 to 15 years, I think there have been some very successful mental health awareness campaigns, such as Bell Let's Talk, and many other campaigns as well. And those have been very successful in getting people to talk about mental health. And I think a byproduct of that is there have been dramatic reductions in mental health related stigma. And that's really good news. More people are willing to talk about what's happening with their mental health. They're more willing to talk about their child's mental health. And these are really good things. And one of the consequences of people being more willing to talk about their mental health or their child's mental health is that you see increases in treatment seeking. Because if people are willing to talk about it, they're more likely to talk to a health provider about mental health as well. And I think what we're seeing in clinical settings is perhaps a significant increase in demand for services. And I can't stress this strongly enough. That is good news. This is what we want to see. I realize that introduces a lot of challenges for healthcare provision, but we want people, if they're struggling with their mental health, to be getting help. And the evidence supports this explanation as well. So that same study that looked at depression and distress in Canadian adults found that over the same time period where the prevalence of depression was not changing among Canadian adults, there was a significant increase in the number of diagnoses of depression made by Canadian physicians. So that seems a bit strange, suggests that physicians are more willing to diagnose somebody and treat somebody with depression. And over the same time period, there's also been dramatic increases in the use of antidepressants and other psychotropic medications. And the authors of that paper concluded that these changes probably reflect changes in diagnostic practice, mental health literacy, or willingness to report mental health concerns. And we've got recently another study from the US that looked at this as well. Again, this is in adults, but I'll come back to children in a minute. So they used data from a nationally representative survey of American adults. And these surveys were done in 2004, 2005, 2009, 2010, and 2014, 2015. So they were looking at the trend over that 10-year period. And I'm going to skip to their conclusions because what they found was that there was a recent increase in outpatient mental health service use, but that was happening during a period of decline in psychological distress. So people's experience of symptoms of depression and anxiety was actually going down at a population level, but help seeking was increasing over the same time period. And they pointed out that their evidence suggests that adults with less serious psychological distress accounted for most of the increase in outpatient mental health service use. So people who in the past perhaps wouldn't have sought help are now seeking help. So again, this is good news. And when we look at this in the context of Canadian children, we'll go back to the Ontario Child Health Study. And one of the reasons this study was done and is so important is that the exact same study was done in 1983. And I think it's really interesting to compare results from 1983 to 2014. So in 1983, if you looked at from the age of 4 to age 16, 16% of the population met criteria for a mental disorder. In 2014, if you look at age 4 to 16, 18.3% met criteria for a mental disorder. So there is a small increase over time, but I would hardly call that an epidemic. But where we do see a really big difference is that if we look at 1983, the number of people who perceived need for help related to mental health of their children, only 6.8% of people perceived a need for help. Whereas in 2014, 18.9% of parents perceived a need for help for their kids related to mental health. So if we look at that in 1983, we've got 16% who are meeting criteria for a mental disorder, but only 6.8% are perceiving a need for help. Whereas in 2014, the numbers with a mental disorder and those who perceive a need for help almost match up exactly. So again, this is a really good news story. And why does it matter if people think there's an epidemic, and why do I care if we call it an epidemic or not? Well, I think it matters because if we say that there's an epidemic, it suggests that something is happening and there's a big change in the causes of mental illness. And if that's the case, when we look at how to tackle that epidemic, we're going to look at recent changes in our population. Whereas if we think that, well, wait a second, this is a problem that's already that has always been there, and now we're just being more open about it, then perhaps we'll look to different solutions. One more quick thing, just looking at numbers over time that I think is also quite instructive, is this is data from US study of high school students that is done every 2 years by the Centers for Disease Control and Prevention. And this is suicidal thought from the early 90s to 2015. So I'll just get you to have a look at that top blue number. That is the proportion of people who said that they seriously thought about attempting suicide in the last 12 months. And if you look at that line from 1991 through to 2015, I think you'd agree that there's a pretty dramatic decline over time. So again, in the context of the historical trend, we've made a lot of progress. Is there some evidence that maybe things have increased from 2009? Yes, that is possible, and it's obviously something we should monitor. But I think the more important thing is just to go back to the overall burden. I don't think we need to say that there's an epidemic to say that we need to focus on mental health of young people. It is the leading cause of disability around the world. So what can we do about it? Are there strategies that we could employ to try and reduce the burden of mental illness that are related to mental health promotion or public health strategies? Well, speaking of possible recent changes in the population, particularly among adolescents, one thing that people are really interested in is screen time and social media. So it appears that screen time is increasing over time. We have many more devices, many more different ways we can be in front of a screen. And social media is certainly one of the drivers of that, and social media platforms are very popular among adolescents. So this is data from the Ontario Student Drug Use and Health Survey. This is from 2013, so these numbers have probably gone up since then, but this is time spent using social networking sites by grades. So you can see that by the time students are in grade 12, the black bar indicates social media use of more than 2 hours per day. So more than 40% of grade 12s are spending more than 2 hours a day on social media platforms. And I'll say again, those data are from 6 years ago, and it has likely gone up since. But debate continues regarding the effect this may have on mental health. So the first idea I wanted to talk about is one that was done, it was led by a PhD student in our lab, Hugues Sampaza-Kanyinga. And so again, he was using this data from the Ontario Student Drug Use and Health Survey and had responses from 753 students in grades 7 to 12. They were asked to report on their use of social media platforms, and it was number of hours per day that was categorized to none, less than 2 hours a day, or more than 2 hours a day. And there were structured assessments of their mental health that included symptoms of distress. So those, again, that's symptoms of depression, anxiety, and suicidal thought. And the rather alarming results from that study were that those who used social media more than 2 hours per day were almost 4 times more likely to be distressed and almost 6 times more likely to be thinking about suicide. So that is really concerning. But one thing about this study that we should tuck away in the back of our mind is that the social media use is measured at the same time as the mental health is measured. So that may raise some questions about the chicken and the egg and which thing comes first. So that's why longitudinal data can be really helpful. And just a couple weeks ago, there was something that was published and got a fair bit of media attention. And this was a British study that was looking at social media use and life satisfaction among adolescents. So these researchers used data from the British Household Longitudinal Study that ran from 2009 to 2016. So they had responses from these adolescents every year for 8 years. More than 10,000 adolescents took part, and they responded how many hours per day they were using social media platforms, and then a structured assessment of life satisfaction, which is related to mental health. And the lead author of this study, when she was talking about this study, said something related to what I just said about the chicken and the egg. She said the previous literature was based almost entirely on correlations with no means to dissociate whether social media use leads to changes in life satisfaction or changes in life satisfaction influence social media use. And again, I'm going to skip to their conclusion here. And what they said is that in this study, we used this very large representative study to disentangle relations between adolescent social media use and well-being. And this is the key thing here. We found that social media use is not in of itself a strong predictor of life satisfaction across the adolescent population. Instead, social media effects are nuanced, small at best, reciprocal over time. So they suggested that social media use may have a very small effect on mental health, but also people who are struggling with their mental health are also more likely to be using social media. And in interviews where they talked about this study, they actually used the phrase where they said the effect of social media use is trivial. So, maybe social media and screen time, it's probably not great, but how does it fit in with physical activity? Well, a student in our lab looked at this in a Canadian study. Again, this is the National Longitudinal Survey of Children and Youth. Almost 10,000 14 to 15-year-olds participated. They reported how many times per week they were physically active. And then they also reported on screen hours per day, and then had a structured assessment of their symptoms of depression and anxiety. What we found in that study was that physical inactivity almost doubled the likelihood of severe symptoms of depression and anxiety. And sedentary behavior and screen time increased the likelihood of severe symptoms of depression and anxiety by 30%. But that sedentary behavior and screen time was not associated with mental health among physically active adolescents. So it was the physical activity that was more important than the sedentary behavior. So if we want to promote child and youth mental health, our first strategy might be, I think it's important to monitor screen time and social media, but possibly more importantly is to encourage physical activity for our youth. Okay, what are some other strategies? Well, how about diet and what kids are eating? Well, there's a growing body of evidence that suggests an inverse association between diet quality and depression. But a lot of that research focuses on specific nutrients. We don't eat specific nutrients. We eat a varied diet where we could have lots of interactions and combinations of different nutrients. So in the past few years, people have gotten really interested in overall diet quality. And the diet that people are most interested in is the Mediterranean diet. So this is a diet where people are eating more fruits and vegetables, they're eating lots of fish, they're eating lots of whole grains, and they're not eating very many processed foods. So people have been interested in linking the Mediterranean diet to mental health outcomes and see if there's an association. Well, the first study that looked at this looked at Spanish university students, and what they were interested in was adherence to the Mediterranean diet. And then they followed these university students over time. And what they found was that people who ate a diet that was closer to the Mediterranean diet were less likely to become depressed over time. Similarly, a study of Australian women, they were looking at overall diet quality. So again, very similar elements: high fruit and vegetables, high fish intake, less processed foods. And they found that the better diet quality Australian women had, they less likely they were to become depressed. So what are the possible mechanisms here? Well, there's a few things that could be going on. So one thing is that oxidative stress is linked to depression. So oxidative stress damages neurons, but we know that fruits and vegetables are high in antioxidants, so that could be helpful for mental health. Another possibility is inflammation. Inflammation has been linked to depression and many other mental disorders. But we know that green vegetables, fruit, nuts, fish reduce inflammation. Another possibility is brain plasticity. So several nutrients have been linked to regrowth of neurons in the brain. So there's a lot of different ways that our diet might directly influence our mental health. So we want to do some research on this using Canadian data. So we looked at the Canadian Community Health Survey, where there's been several waves every year or 2 years by Statistics Canada, where they interviewed thousands of Canadians. We were looking at people age 12 and older. We were interested in particularly in fruit and vegetable intake. So people were asked about how frequently they ate fruits, green salad, carrots, and other vegetables. And then they had a structured assessment of depression in the last 12 months, also distress. And we were able to include more than 240,000 people in this study. And what we found across 4 different waves of this study was that the more fruits and vegetables people ate, the less likely they were to be depressed, and the less likely they were to be distressed. Now, these were cross-sectional studies where people being interviewed about diet and their mental health at the same time. So ideally, we would use prospective studies. So we were able to do this by working with some researchers from Nova Scotia, where they had done a study of grade 5 students and done a very structured assessment of their diet. We then linked them, the participants, to their healthcare data and followed them up for 3 years to see if they had mental health disorders that were diagnosed by a physician. The diet assessment they did measured variety in their diet, adequacy, so whether or not they're being undernourished in any important areas, moderation, so whether they're getting too much in any area, and then balance, which is just the proportion they're getting from different sources. And we were interested in whether they had a diagnosis of any depression or anxiety disorder between the ages of 10 and 13. And what we found was that the most important thing in terms of their subsequent mental health was that those children who had a lot of variety in their diet were much less likely to be diagnosed with a depressive or anxious disorder in the following years. So this suggests that diet is associated with common mental illnesses, that fruit and vegetables might be a really important indicator of a good diet, and that variety might really matter, because if you have variety in your diet, you're more likely to get the good stuff that matters. Now, the causal picture can be a bit messy, because we know that people who have a healthy diet tend to have other really healthy behaviors. So they're more likely to be physically active, not to be smoking, to be drinking less, and so on. So best we could do is have a randomized controlled trial that would show us whether or not there's actually a causal link there. And here's somebody saying, I used to think correlation implied causation. Then I took a statistics class. Now I don't. And the friend says, sounds like the class helped. And the first person says, well, maybe. And I'm sure you're all chuckling out there. Statisticians and epidemiologists think that joke's hilarious. So there has been a randomized controlled trial of a diet intervention. So this was an intervention where people with depression were coached on how to have a more healthy diet, and that was to increase whole grains, vegetables, more fish, and less processed foods. And it's really important here to note that the diet intervention was added to their regular treatment that they were getting for depression. The comparison group got their regular treatment plus a social support intervention. And then they were looking at the outcome was symptoms of depression at the end of 12 weeks. And what did they find? Well, they found that both groups improved over 12 weeks, and we would expect that because they're being treated, and we know that social support interventions work. But the group that got the diet intervention actually did a lot better than the social support group. And these authors concluded that dietary improvement may provide an efficacious and accessible treatment strategy for the management of this highly prevalent mental disorder. They're talking about depression here, the benefits of which could extend to the management of common comorbidities. So if you have a more healthy diet, not only is it going to help with your mental health or your child's mental health, but it may also help with other physical health problems as well. So our second strategy for promoting child and youth mental health is to promote a healthy diet. What else can we do? Well, what about neighborhoods that children live in? Well, there's been a lot of research over decades really showing that there's a link between disadvantaged neighborhoods and mental health problems. Negative perceptions of neighborhood safety is associated with mental health problems. And there's been suggestions that the social capital of a neighborhood may be protective. So this is kind of how connected a neighborhood is and how people how connected people feel to their neighbors around them. But there's not a lot of evidence looking at these effects over time. So we looked at this again in the National Longitudinal Survey of Children and Youth. Mothers had been repeatedly asked about the neighborhood that their children were growing up in, and they had to agree or disagree with 5 statements. So, for example, people around here are willing to help their neighbors. Then we looked at kids' experience of cohesion, how cohesive their neighborhood is around them from early childhood to adolescence. We had more than 5,000 kids. So here's a guy saying, "Hey, Wayne, could you look after my house while I'm away on vacation? I'd hate to have something go wrong and not have anyone to blame." Shouldn't we all be so lucky as to have neighbors like this? Well, what did we find? We found that kids who grew up in neighborhoods with low cohesion were more likely to be depressed and socially aggressive. And this is after accounting for how safe a neighborhood is and its socioeconomic status, so neighborhood income. We also found that kids who were experienced increasing cohesiveness over time, so either their neighborhood was getting more cohesive or they moved into more cohesive neighborhoods, were less likely to be hyperactive in adolescence. But if they were experiencing decreasing cohesiveness over time, they were more likely to have symptoms of hyperactivity in adolescence. And then the last thing was early childhood exposure to highly cohesive neighborhoods increased the likelihood of adolescent prosocial behavior. And that was whether or not kids stayed in highly cohesive neighborhoods or whether they were in a cohesive neighborhood early in childhood and then their experience of cohesion went down over time. They were still more likely to be prosocial as adolescents. We collaborated with some British colleagues and found something very similar, where many thousand children were followed from birth until adolescence. And we found that children who grew up in neighborhoods that had low social cohesion were more likely to be depressed at age 18. And then a paper that's just going to be coming out in the next couple of weeks, we looked at the association between stressful life events and then mental health and behavior, because we know that when children and adolescents experience major stressors in their life, they're more likely to experience problems with their mental health. And we wanted to see if this relationship differed at all according to how cohesive the neighborhood was around them. And what we found was that this link between stress and mental health was lower in cohesive neighborhoods. So this suggests that being in a really cohesive neighborhood builds resiliency among children. So I think I've said this. Kind of the key takeaway here is that there is evidence that relocation for low-income families improves mental health, but obviously relocation isn't very realistic to move entire communities. So I think we should be thinking more about community functioning interventions, and I think some of these can be really simple. They've been shown to improve some health indicators, but I think we need a lot more evidence. One of the ways that living in a cohesive neighborhood may help is that it provides social support, and we know that social support can be really important to promote mental health. So stress is strongly associated with depression. We wanted to know whether social support could modify the effect of stress. Social support can positively help you reframe negative things that can happen. If you have good social support, this is going to help promote your own self-efficacy. People may provide new coping mechanisms, and they may support healthy behavior changes that would be good for your mental health. So we looked at this question, whether or not this would be the case in the National Population Health Survey. We had more than 1,000 16 and 17-year-olds complete social support questionnaires, and they were then followed every 2 years over a 10-year follow-up period. They reported on personal stressful events, workplace stress, and financial stress in early adulthood. And they also completed a structured assessment of depression. And what we found was that adolescents who reported higher levels of social support were, as adults, less likely to become depressed when facing high levels of stress in the workplace and less likely to become depressed when experiencing financial stress. So this suggests that social support builds resiliency and helps people to face stress. And you may think, well, that's great. How can I introduce social support for somebody? But one possibility is, well, can we just kind of force social connections onto people? Can we just give people friends? Well, there's actually been a review of the research in this area, and this is these kinds of interventions are called befriending interventions. So befriending is defined as an intervention that introduces the client to one or more individuals whose main aim is to provide the client with additional social support through the development of an affirming, emotion-focused relationship over time. And the key thing here is that befrienders could be untrained lay persons. So really, they're just people who are trying to provide social support for somebody who, in this case, is suffering from symptoms of depression. And what that review concluded was that compared with usual care or no treatment, befriending had a modest but significant effect on depressive symptoms in the short and long term. Okay, so this doesn't have to be something really complicated or intensive, but just trying to introduce social support can be really helpful. Okay, so what can we do to promote child and youth mental health is to pursue social connections. The next thing I want to talk briefly about is parenting. Parents are obviously strongly involved with their children, but what about how parent behavior may affect children? Well, again, in our Canadian study, they asked parents about positive behaviors they engaged in with their child. So whether they praised their child frequently, whether they laughed together, whether they spent time together doing something the child enjoyed, and then whether they employed harsh disciplinary measures. So things like yelling at a child using physical punishment. We were interested in parenting practices in mid-childhood and then how the children were doing with regards to their mental health in adolescence. And what we found was that positive parenting was linked to reduced depression, anxiety, reduced symptoms of hyperactivity, reduced conduct problems, and reduced suicidal thought, particularly among girls. And that harsh disciplinary practices were linked to increased depression, anxiety, increased hyperactivity, increased conduct problems, and increased suicidal thought, particularly among boys. We also found indirect associations where we've showed that positive parenting practices leads to better mental health and behavior, and subsequently leads to reduced suicidal thought, and harsh disciplinary practices lead to worse mental health and behavior, which leads to increased suicidal thought. And parenting practices may actually buffer against stress. So we have looked at cyberbullying in the Ontario Student Drug Use and Health Survey. And what we found was that, not surprisingly, cyberbullying is associated with distress and suicidal thought, but parenting modified this relationship. So boys who reported a positive relationship with their parents showed no association between cyberbullying and distress. So again, parenting practices may help children become more resilient. The more positively you can interact with a child, it may lead to positive outcomes for the child. So our fourth strategy is we can practice positive parenting. Okay, and now I know I'm getting a bit short on time, but I am getting near the end. I want to talk a little bit about suicide contagion. So StatCan, in the National Longitudinal Survey of Children and Youth, asked respondents, has anyone in your school died by suicide? And by the age of 16 or 17, almost 1 in 4 are reporting that someone in their school has died by suicide. And that may sound like a very high number, but if you think about it, if there's 1,000 kids at a school and one died by suicide, everybody's going to hear about it. They also asked, has anyone you known personally died by suicide? About 1 in 5 responded that they did. We were interested in how being exposed to someone else's suicide might affect somebody's own thoughts about suicide. And what we found was that students who reported that someone in their school has died by suicide in the past year were much more likely to be thinking about suicide themselves. And that's after accounting for things like their own symptoms of depression and anxiety, previous suicidal thoughts of their own, substance use, or other major stressful events. And that if they're exposed to suicide by someone they know personally, they were also more likely to be thinking about suicide themselves. That has led us recently to look at contagion from non-suicidal self-injury. So in the Ontario Child Health Study, kids who are between the ages of 14 and 17 were asked, sometimes people deliberately harm themselves, but they do not mean to take their life. In the past 12 months, did you ever deliberately harm yourselves, but not mean to take your life? And then, so that's an indication of non-suicidal self-injury or deliberate self-harm. But they were also asked, in the past 12 months, did any of your friends deliberately harm themselves but not mean to take their life? And almost 1 in 4 reported that they had a friend who had engaged in non-suicidal self-injury. And people who were aware of a friend's non-suicidal self-injury were twice as likely to report non-suicidal deliberate self-harm themselves. They were 3 times as likely to report recent suicidal thought and almost 3 times as likely to report a recent suicide attempt. This shows that exposure to deliberate self-harm and suicide is very common. These effects can't be explained by co-occurring mental disorders among both the person who has died and the other people, because we've accounted for that in these studies. These effects may last longer than anticipated. So in the longitudinal study, we were able to look and show that 2 years later, children were still being affected. And a key thing here is that postvention strategies targeting high-risk youth may be missing those who are equally affected. So among people who reported that they had someone in their school had died by suicide, they were equally affected whether or not they personally knew the person who died or not. So I'm going to talk quickly about one other study that has looked at suicide contagion and specifically looking at the media. And then I'm going to wrap up. So this was a study that looked at newspaper coverage of teen suicides, and they were comparing communities where there had been a single teen suicide to communities where there had been a cluster of teen suicides. And what they were interested in was the media coverage of the first suicide in the cluster to the media coverage of the teen suicide in the community where there was no cluster. So there was no follow-up suicides. What they found was that in the communities where there were follow-up suicides by other teens, there were more stories in the newspaper about that first suicide, and those stories were more likely to be on the front page, to contain a photo of the deceased, to use the word suicide in the headline, to mention and describe the method used, to identify a single cause for the suicide, and to name the school the deceased attended. And I'll just point to 2 things on that list. One is when the media talk about a single cause for the suicide. The reason that's dangerous is that if you talk about a single cause, it increases the likelihood that other people are going to identify with that single cause. So if we say that this person took their life because they were being bullied, then other children are more likely to say, well, wait a second, I'm being bullied, so maybe this is a solution to my problems. The reality is that, of course, there are causes that are really traumatic, such as bullying, but usually there is a complex constellation of contributors towards a suicidal death. And then the second thing is that when the media mention or describe a method used, they're not only saying, hey, this may be a solution to your problem that's similar to the problem that the child who has died was experiencing, but here's how you can do something about it. And that is exceptionally dangerous. So I think it's important for us to talk about suicide and suicidality, but we need to do it in a really responsible way, and in a way that children can talk to adults, their parents, their families, their loved ones, their health providers about what they're experiencing. And that's why we have media guidelines for reporting suicide. And in this case, this study showed that we shouldn't be doing a lot of these things, and the guidelines are really important to follow. And I think it's really concerning as the media landscape gets more fractured, how we're going to be able to implement these kinds of guidelines moving forward. But I just mentioned, I think, we can talk about suicide responsibly. And I think one example of that is a cover story from the Christian Science Monitor, where they were talking about suicide contagion, but they spun it in a way with this headline: teen suicide, prevention is contagious too. And although they talked about suicide contagion, they spent a lot of that article talking about prevention programs that are being implemented around the country. And I think that's really important. So what can we do to promote child and youth mental health? Our fifth strategy is to practice responsible postvention, to make sure that children have a safe place where they can talk about how they're feeling about the death of a schoolmate or a loved one. And the last thing that I'll just mention, because it's obviously a huge contributor when it comes to child and youth mental health, but it's a lot harder to tackle from a public health point of view, is that exposure to traumatic events and chronic stress really has a strong influence on child and youth mental health. So any way we can try and protect children from trauma and stress is going to have positive effects. So I'm going to stop right there, and thank you very much for your attention, and I apologize for going a bit long.
Thank you very much, Dr. Colman. I mean, that was really a fantastic presentation. If you could see the comments, lots of people agreeing with me. You've covered so much ground, and we could have possibly even split this into 2 webinars, possibly. And I do want to assure you that I did find the epidemiology cartoon very funny. So
thank you.
You were wondering. So we do have a few questions, if you're okay. We are past our 12 o'clock usual stop time, but there's a couple of interesting questions if you're able to stay around for 5 minutes or so.
Sure.
Yeah, so I'll sort of start from the end. I'm going to go from the bottom up. Some of the more recent things that you were talking about, just in the media and the suicide contagion and that sort of thing. Someone asked about shows like 13 Reasons Why that is about or has a component about suicidality in youth. Just wondering if, in addition to other suicides in a school potentially being a suicide contagion, is media that supports suicide, has that been shown to increase suicidality at all in any way that you're aware of?
Yeah, so people were really concerned when 13 Reasons Why came out. It was exceptionally popular show among adolescents. And a lot of people, including myself, were contacted by the media and saying, hey, are you concerned about this? And we tried to raise a lot of awareness about it. And unfortunately, there is recent research showing that shortly after 13 Reasons Why was released, there were increases in suicide attempts. I believe that was in the US. There were some positive things about the show, and I think there are things, the show could have been used if, we knew that every parent was sitting down with their child to watch the show, and then they could talk about it and say, maybe this character could have approached this differently, or what did you think about this? Then maybe that is helpful. But just sending that out and having adolescents sit in front of a screen and being confronted with some really disturbing content, I think is really dangerous.
The next question is in relation to the Ontario Student Drug Use and Health Survey, and this question came in before, and just shortly after you or this question came in, you did present a slide there where you were talking about this particular survey. But the person was asking what you can make of in that survey. It sounds like you are somewhat familiar with it. It showed the percentage of teenagers experiencing moderate to serious distress had increased from 24% in 2013 to 34% in 2015 to 39% in 2017. Just wondering if there's anything you can comment about what might be the cause. I think you were talking about cyberbullying and some other things in relation to that study. But can you give us a comment about what would potentially have been causing that increase in distress?
Yeah, I mean, it's difficult to say, because one of the things that we can't really, it's really difficult to disentangle, especially in kind of a population health survey, is whether people's willingness to report symptoms also is changing over time. Because as stigma reduces, certainly people are more willing to report things that they may not have reported before. So that may be part of the explanation, but it's possible. I mean, it is possible, but it's hard to figure out how there could be such a dramatic increase in such a short period of time. There are things that we should be worried about, like cyberbullying, other things around social media, but it is difficult to disentangle. I just think it's really important to acknowledge that we really need to make child and youth mental health a priority.
That whole question of sort of disentangling what the reality is behind the numbers, that was actually a question that came in early on. They started their question by asking about some of the trends and that sort of thing that you were presenting at near the very beginning. Are you aware of studies that had accounted in any way for demographics associated with those? So looking at, there is no the trend in suicide and depression and that sort of thing is not increasing, sort of as you were presenting the case that there's not really an epidemic happening, regardless of the magnitude of the problem. Are you aware of any work that's been done to sort of look at that from some of the individual demographics within that? So adolescent boys versus adolescent girls, for example, we've seen some very public, very high profile cases in sort of Northern Ontario and Saskatchewan, some of those associated with Indigenous communities. Do you know if anyone's sort of looked at sort of unpack some of the demographics in there? And the question did go on to talk about, wondering if there are qualitative and mixed method studies that have sort of gone on to sort of untangle some of these stories. And you did talk about that with the study out of the UK around the social media. So some of that is being done around going beyond just the numbers and digging a little deeper. But are you aware from that demographic perspective of any work that's being done to sort of see if there are particular problems within the overall population?
Yeah, sure. I mean, I think there's a lot of variation within the population, and I was just talking about kind of the broad overall picture. I think it's very likely that the different subgroups within the population may be being affected differently. Some may have increasing symptoms over time. Some may have decreasing symptoms over time. But there's a lot of studies where people are looking at kind of these subgroups. And I'll give you one example that I debated whether or not to talk about, but I really did want to focus a bit on kind of strategies. But there are some, I think, legitimate concerns around deliberate self-harm in the adolescent population. Although rates of suicidal thought and suicide attempt don't appear to be changing very much over time, the rates of non-suicidal self-injury, so that is deliberate self-harm where someone doesn't have the intent to take their own life, that seems to be increasing over time. Again, it's hard to say whether or not people are just more willing to report this, but there's certainly, it's getting compelling enough that it's looking like there may be increases over time. And that's really dangerous because the more people become comfortable with harming themselves, the more this becomes a normalized behavior, the more likely it is that those people may start thinking about suicide, because the research does show that people who deliberately harm themselves without the intent of dying are actually more likely to subsequently start thinking about suicide.
There's one more quick question and then one more actual question. There are a number of people are asking if they can get a copy of the slides from this. I did notice you mentioned a couple of the slides were referring to upcoming publications, so things that had not been published. So I'm not sure if you're able to share the slides with us, but do you think you would be able to?
Yeah, I think so. I may. What I might do is provide a version where I'll just leave a couple small things out because they're currently under review.
That would be absolutely fine, and we'll put that on our Knowledge Exchange network where we put the recording for this as well. So the last question I just wanted, there are a bunch of other questions. I apologize to the audience. We won't be able to get to all of them. There's actually quite a number of questions left, but it was just an interesting question from a service delivery perspective, given that that's where most of our audience comes from, is that health service delivery organizations. She's just sort of interested, making some interesting observations about the data from the US versus the data from Canada, and you had lots of both. It's great to see we're not relying on US data, that there's lots of studies on the actual Canadian data, but just wondering about the impact of universal health care and how that might affect mental health diagnosis and treatment, looking at comparing instead to the US, but to the UK or other countries that might have a more similar healthcare system as far as universal healthcare. Just wondering if you're aware of any obvious differences, or anyone who's done any work around the impact of universal healthcare in Canada versus the US that might affect any of this sort of thing?
Yeah, that's a really good question. It's really difficult to study because there's so many moving parts, and then you've got one country where there's universal healthcare, or maybe a few countries where there's universal healthcare, and a few other countries where there isn't, and there's so many other differences between those different countries. So it's difficult to tease that out. I think it is likely to influence people's willingness to seek treatment, which is obviously a good thing. I think in a setting where there is universal healthcare, people are more likely to get help, particularly among those who are experiencing more of the mild or moderate symptoms. There may be barriers in a private healthcare system, particularly that's associated with education, socioeconomic status. Those people are likely to have much bigger barriers to accessing the healthcare system.
Yeah. All right, and I think with that, we'll wrap it up. I mean, again, I just want to we'll give you one last. I want to hand it back to you, just one last opportunity to provide any sort of closing comment or key message, or let us know what's coming next from your lab that people might be interested in. But I just thought it was interesting to look, your last slide where you had, again, I think you had 6, things that might be making a difference. And I've heard people at other conferences, someone presented and said, really, what it boils down to, if people had a stable home, a job, and a friend. Most mental illness we'd be able to address mental illness with just that, and you sort of captured some of that in addition to a few other points. But it really does come down to some of those basic, human needs is really what's going to help us address the problem. So I thought that was quite interesting. But just any last closing comments you'd like to make before we sign off?
Yeah, I mean, I think maybe I was trying to be provocative by asking the question of whether or not there's an epidemic, but regardless of whether there's an epidemic, there is a massive burden, a huge need for mental health care. And there are, apart from clinical strategies, there's a lot of evidence that some of these kind of public health, health promotion strategies can help children and adolescents who are at risk of mental illness or who are experiencing mental illness.
Your email address was on the screen. Is that, if people do have questions, should we invite them to contact you by email?
Sure.
All right. And I believe it was icolman@uottawa.ca, I think was what was up there. But
yeah, that's right.
All right. Well, thanks again very much. And I think this is where we'll wrap it up. But fantastic presentation. So thanks so much for joining us today.
It was my pleasure.
All right. So we do our webinars every Wednesday at 11 a.m. Eastern time, and when you do get to watch live, you do get to participate in the comments and the questions, which is always great. But when you can't watch live, we do make these sessions available after the fact, and all of the attendees will receive an email with a link to the recording, and hopefully we'll have a copy of the slides to go with that shortly. Usually it takes us a couple of days to get those up. Our next webinar next Wednesday on June 5th, we will be talking about SKIP, Solutions for Kids in Pain, which is a new knowledge mobilization initiative. And it's really our pleasure, an honor to be able to say that we are. This is a network that Children's Healthcare Canada is partnering with Dr. Christine Chambers at Dalhousie University, and this is a new program that's been funded by the Networks of Centres of Excellence, and this is a new knowledge mobilization network seeking to bridge the gap between current treatment practices and available evidence-based solutions for children in pain, knowing that Canada is a global leader in children's pain research, and yet it still takes about 17 years for that research to end up in clinical practice. So come and join us next week to learn a little bit more about SKIP, what we're planning to do with SKIP, and how you can get involved. So it'll be a great session next week. And also I want to remind everyone to sign up for our Children's Healthcare Canada Spark newsletter so you can stay up to date on all of our activities and events, and you can sign up there by going to our website at children'shealthcarecanada.ca. And so thanks again, everyone, for joining us today. Thanks again to Dr. Colman for a fantastic presentation, and hopefully we'll see everyone back here next week. Bye, everyone.